Good evening, everyone. Today I'll be talking about hydatid disease, which is one of the commonest questions asked in the DNB surgery exams. Hydatid disease is very common in our country and especially the northern part of the country. And there are various presentations. It can affect all ages, all sexes, and can present in the various symptomatology. So we'll just have a little bit of an insight about this. So echinococcosis is a disease caused by the echinococcus is a disease caused by the larval form of the Echinococcus granulosus. The adult worm lives partially parasitically in the intestine of a definite host. So here we will discuss about the hydatid in these subheadings like introduction, life cycle, pathogenesis, clinical features, diagnosis, and treatment. Though most of it is in the literature and there is a clear-cut idea about how to treat this, still there is a debate about laparoscopic and the conventional method. But studies-wise, it is found that laparoscopical approach to the hydatid cyst of the liver or the any abdominal viscera is equally good enough as compared to the uh, open method. So this is a classical picture of the echinococcus cysts and a CT picture of the same cysts in the diagram here. So to come to the echinococcosis is a parasitic disease caused by the infection of the with the tiny tapeworms of the genus Echinococcosis. They are classified as either cystic echinococcosis or alveolar. These are the two common things which we find. There are other two variants also. Cystic echinococcosis, otherwise known as the Hydatid disease, which we are discussing here, is caused by the infection with the larval stage of the Echinococcus granulosus, which is around 2 to 7 millimeters long tapeworm found in the dogs, which happens to be the definitive host, and sheep, cattle, and goats and pigs, which can be intermediate hosts. Although most of the infections in the humans are asymptomatic, it can cause harmful effects by slowly growing in size, affecting the liver, lungs, and other organs. They often grow unnoticed for a long time. Alveolar echinococcosis disease is caused by infection of the larval stage of the Echinococcus multilocularis, 1 to 4 millimeter long tapeworm found in foxes, coyotes, and dogs. It can pose a much greater healthy threat to the people than the cystic echinococcosis, causing parasitic tumors that can form in the liver, lung, brain, and other organs. If left untreated, it can be fatal. Hippocrates recognized human hydatid over 2000 years ago. The Arab physician Al-Razas made a reference of the hydatid disease 1800 years. It is a zoonosis caused by platyhelminthes. Echinogonoglossys produces unilateral cystic lesions also. As I mentioned earlier, it is prevalent in China, Central Asia, then Middle East, Eastern Africa, and part of South America also. WHO has done a series of uh, tests and programs to contain this disease, and it is found that both cystic echinococcosis and alveolar echinococcosis represent a substantial disease burden. At any given point of time, there may be around excess of more than 1 million people suffering with this disease. Many of these people will experience severe clinical syndromes which are life-threatening if left untreated. Even with treatment, people often face reduced quality of life, which is important. Sometimes it can recur and there can be multiple procedures or multiple treatments required for the patients, and sometimes it can be difficult to operate. So it can cause a severe disability, especially in the endemic areas. For cystic echinococcus, there is an average of 2.2% post-operative death rate for surgical patients and about 6.5% case of relapse after intervention. Thereby, this disease requires a prolonged surveillance as well as a treatment wherein the recovery time is prolonged. This is the typical life cycle of the hydatid cyst. So the lives, adult worm lives parasitically in the intestine of a definitive host like a dog, wolf, and other animals. The ova which passes in the feces are ingested by grazing animals like sheep. The intestinal juice free the ovum from its cuticle, and having entered the capillary, it is carried in the bloodstream to the liver and lungs. Wherein it develops into a hydatid. Man becomes infected by eating contaminated vegetables or drinking water which is contaminated by dog feces. The commonest organ in the humans are involved are the liver. So, most common is the segment 7. Sometimes both the lobes can be involved or only the left lobe. The other organs which can be affected are liver, spleen, brain, and even it can be seen in the muscles in the various areas of the body. As mentioned earlier, they spread through the capillaries of the intestine and get lodged in the liver. Other organs, as I mentioned earlier, can be lung, brain, and bone. Following tissue lodgement, the cystodes proliferate. Proliferation occurs in the form of slowly growing cyst. In the 80% affected individuals, the only manifestation of this disease is solitary cyst in a single organ, but they can be present in various multiple organs or multiple cysts, which can produce a potential threat for the treating doctors and more chances of recurrence or refractory cysts. Coming to the morphology of the cysts, primary cyst is in the liver is composed of three layers. That is, one is the adventitia, consisting of the compressed liver parenchyma and a fibrous tissue. It is usually represented as a pseudocyst. The laminated membrane, the ectocyst, is the elastic white covering, easily separable from the pseudocyst. There is a germinal epithelial layer, which is a single layer of cells lining the inner aspect of the cyst and is the only living component, being responsible for the formation of the other layers, which swells the fluid and brood capsule within the cyst. The hydatid cysts are very slow growing, approximately 1 to 3 centimeters in a year, and can remain inapparent for a long time. This is the classical picture of the hydatid cyst which I mentioned. You can see the pericyst, ectocyst, endocyst, and the daughter cyst with the various morphological features of the worm. Any questions here, sir? Hello.
Chat box, I don't see any questions. Postgraduates, any questions?
So WHO classification was there, no, for
Yes, I will come to that, sir. It is a radiological
right,
finding. So during the
investigation,
I'll come there, sir. Investigations, I'll come there, sir.
Postgraduates, why the right lobe is more common, hydatid cyst?
Sir, because portal vein is more straight entering the liver, sir, into the right lobe, and also because it is larger than the left lobe.
Right. Most of the blood supply which comes through the portal vein, where it can lodge in the right lobe more. And also Dr. Mahesh said right lobe segment 7, Allah, right?
Yes, sir. Segment 7, sir. Yes, sir.
Okay, any other questions? Otherwise, it can lodge anywhere in the body if it escapes the liver filter.
Similarly, the right lung also is the commonest area because of the the anatomy of the right bronchus, sir. Actually, yeah.
Right.
Sir, what percent of this will come as anaphylactic shock, sir? Any means how many people will come with anaphylactic shock from rupture of this cyst?
There is no mention about that, but it is very rarely found that patient present with anaphylactic shock secondary to a ruptured hydatid cyst.
Very rare.
Okay.
Very
Less than 1% of people. And we have not seen any of them. Dr. Noli, sir, have you seen any many who had anaphylactic shock and come to emergency?
No, sir. No, we have not seen, sir.
More
They literature says 0.1%, sir.
correct, less than, yeah. And it's very rare. Even during surgery, when there is spillage, anaphylactic shock occurring is very, very rare,
We have not come across, sir.
even though we are all very much worried about it. So there is a question, what is hydatid sand? I think he will explain it when you come for imaging or so.
Imaging, sir. Yes, sir.
Let's leave it that. I think you can go ahead, Dr. Mahesh.
Yes, sir. Coming to the clinical feature of this disease, as I mentioned earlier, it is almost common in both male and females. And studies-wise, some papers mention an average age of 45 years, 45 years when they present. As sir mentioned earlier, 70% are located in the right side of the liver and are solitary. Usually, they are asymptomatic until they get complicated. That is, most of the symptoms may be due to compression or obstruction or displacement of the adjacent organs or structure. Commonest symptoms when the cyst enlarges or ruptures can be abdominal pain, dyspepsia, and vomiting, depending on the area which is being affected. Some patients may present with obstructive jaundice due to compression of the cyst on a particular area in the liver. And also, in children, they can have chronic abdominal pain, failure to thrive, and also we can see wasting of the muscles. Clinical signs depends on the organs which are affected. Can be hepatomegaly, or if there is a large cyst in the liver, it can be splenomegaly. There can be an elicitation of a hydatid thrill, which is otherwise called as a three-finger test. And sometimes in children, as I mentioned earlier, they can be cachectic, is followed by an intraocular rupture, and the cyst would have partially collapsed. Just question for the PGs. Can anyone mention about how to do this three-finger test and how the hydatid thrill is elicited?
Anybody? I think many people may not have seen Mahesh, you only explain.
Yes, sir. Yeah, the hydatid thrill is rare but a pathognomonic sign of hydatid disease. The thrill occurs when a mother cyst packed with unruptured daughter cyst are gently percussed. The consistency of the wall of the daughter cyst and the tension of the fluid inside are responsible for making the cyst to vibrate and produce the sensation of a thrill. The free fluid from a ruptured daughter cyst dampens the vibration. It is extremely rare for the mother cyst to have all the daughter cysts in an intact condition. So it is like cyst in a cyst. So it's like bouncing within each other. That's what is the thrill which is felt.
How do you elicit it?
It is between three fingers on the abdominal wall, with the middle finger acting as a percussing finger, and the thrill is felt by the other two fingers.
Right.
Sir, is it your dog?
Hello?
1 second, sir. Just give me a minute.
Dog.
He also wants to speak.
Dr. Nolis, were anytime able to elicit hydatid thrill?
No, sir, no. First time I heard, sir, this hydatid thrill.
Yeah, it's all given in the books, but clinically not possible.
No, no, sir, no, sir.
Especially the large, it says in the book, but it's very, very difficult actually, sir.
Continue, Mahesh.
Yes, sir. Coming to the complications, as I mentioned earlier, jaundice due to pressure over the biliary. If there is any compression of the portal vein, that can lead to portal hypertension. There can be a rupture into the biliary tree, may mimic a recurrent cholestasis or biliary obstruction, or sometimes leading to cholangitis. It can rupture in the peritoneal cavity and may cause potential fatal anaphylactic reactions with a disseminated intra-abdominal echinococcosis. There have been some papers which has found in a direct hernial sac, they have these echinococcal cysts. So that indicates that probably the cyst has ruptured sometime without any symptoms to this patient, and that has been successfully retrieved from a direct hernial sac. It can rupture into the bowel or the pleural cavity. Bacterial superinfection of hydatid cyst can occur and can present like a pyogenic abscess, which can be fatal to the patients. There can be erosion into the surrounding structures or organs and may result in hematogenous dissemination. Sometimes, as a sequelae, the parasite may die and cyst eventually may get calcified, which can be incidentally found on X-ray of the chest or the abdomen for various other reasons. Cyst may get accidentally ruptured secondarily by a blunt trauma of the abdomen. Usually, the splenic cyst can actually have the similar problem. Once we have diagnosed and various investigations are required for this, uh, routine labs and which can indirectly contribute to the long-term or a chronic cyst. There can be elevated bilirubin and alkaline phosphatase. In some patients, there can be leukocytosis. Eosinophilia is in 25% of the infected cases, but it can be due to various other infestation also. There are various tests like Cassoni's tests and serological tests which are done. Most of them helps in prognostication of the disease to prevent recurrence, to detect recurrences rather than helping to diagnose or treat these patients. Uh, so the important diagnostic modality for the diagnosis of the abdominal or the hydatid cyst is the ultrasound. X-rays can be useful sometimes where there is calcification, thin rim of calcification can be seen. The current ultrasound is supposed to be currently the primary diagnostic technique and has 90% of diagnostic accuracy. Uh, as the dependent debris which are found in the cyst are called as the hydatid sand. There can be a presence of wall calcification and localized thickness in the wall corresponding to early daughter cysts. Daughter cysts are characteristic signs with cysts within the cyst, as I mentioned earlier. They can be called as cartwheel or a honeycomb cyst. So this is the classification Dr. Nooli was mentioning. There are two classifications which are used worldwide. One is the WHO and the other one is Professor Garby's classification. Most of them uses the ultrasound as a modality to distinguish the types or stages. They are like, as mentioned here, unilocular cysts and cysts characteristic with wall and mobile internal echoes. And the CE2 is multivesicular, multiseptate cyst, daughter cyst, and honeycomb pattern. There is the water lily sign, which is CE3. Then the CE5 is cyst with the partial or complete wall calcification. This classification helps to treat the cyst according to the various treatment modalities available, which I would discuss as we go forward. Any questions in this, sir?
Yes, Mahesh. Dr. Ravishankar says Cassoni's test is mentioned for posterity. I think recent books are also stopped mentioning about
Yes, sir. That's what I mentioned actually. It is not useful these days, actually, sir.
For theory's sake, he has told. Dr. Noz is telling what is cystic echinococcus and alveolar echinococcus, which of the two is dangerous. Anybody postgraduates?
Alveolar.
Alveolar.
Yeah.
What is the name for it? What hydatid it is known as? There is another called malignant hydatid disease.
I have mentioned in the first few slides that it can be fatal. They are slow growing tumors and they require radical surgeries to prevent problems, and they are the most dangerous among the
No.
hydatid cysts, sir.
Postgraduates, Mahesh.
Sorry, sir. Okay, I thought.
Malignant hydatid cyst. Anybody?
Multilocularis, sir. Echinococcus
Echinococcus multilocularis. No?
Yes.
Because whatever you do, it's going to come back. It's an aggressive disease. That's why it's not a malignant disease, but it's known as the malignant hydatid cyst disease. Any other questions?
Okay. Sir, I want to ask why there will be dyspepsia in hydatid, sir?
Okay, Mahesh, why there will be dyspepsia in hydatid disease?
One is the liver enzymes can get altered because of the compression or rupture in the biliary system, which can indirectly give rise to dyspepsia, which can be similar to, as I mentioned earlier, like symptoms of cholestasis or cholangitis. So probably altered liver enzymes can lead to dyspeptic symptoms, sir.
Also, maybe sometimes pressure effect. A lot
Pressure of the is a large
of stress on the
cyst
spleen
also.
or duodenum.
Yes, sir. Yes, sir.
I think there will be say, maybe if not reduction, compression of the normal liver tissue.
Yes, sir.
So when there is, there will be maybe degree of cholestasis as well. So all of
Yes, sir.
these leads to sense of fullness and then dyspepsia.
Correct, sir. Yes.
Right. Shall we move ahead, Mahesh?
Yes, sir. Apart from ultrasound, which is the commonest modality to diagnose hydatid disease, CT scan has also got highest sensitivity compared to ultrasound up to 98%. It is the best mode to detect the number, size, and location of the cyst, which can give more information compared to an ultrasonogram. Complications such as infection and intrabiliary ruptures are much easily or clearly diagnosed with the help of the CT scan. And it also helps the surgeon to plan his surgery appropriately. MRIs also provide excellent structural details and maybe a little superior than the CT scan, demonstrating the hepatic venous system. Their MRCP is helpful if there is a cystic biliary fistula, which can help the management of the patient, which may require an ERCP and draining of the cyst in the biliary system. Coming to the treatment part of it, there are various modalities, as I mentioned, drug therapy, then percutaneous interventions, endoscopic methods also been tried, surgery between open and lap, and some physicians or surgeons adapt this wait and watch technique to see how the cyst progresses. But most of the centers or most of the papers mention about treatment depending primarily based on the ultrasound images of the cyst. This is an algorithm adopted by some centers for the treatment. All modalities are mentioned here, like imaging, then followed by uh, chemotherapy, and then ultrasound guided aspiration, then surgical removal with the laparoscopic as well as the open method and the wait and watch method. This is a simple protocol followed by some of the centers. Coming to drug therapy or chemotherapy, the albendazole, the antihelminthics, stands the main drug of choice. Praziquantal is used wherever there is allergic reaction to albendazole. A standard adult dose of 400 milligram twice daily is given in cycles of 28 days with a 2 weeks treatment-free period. And also inoperable in cases of inoperable in patients who are inoperable, a primary treatment of 3 cycles are given, and preoperatively also as a adjuvant therapy to reduce the risk of recurrence in 6 weeks discontinued. Postoperatively, to prevent recurrence in case of intraoperative cyst spillage, we can continue with 3 cycles of 28 days each. Drug therapy, as I mentioned earlier, the indications are adjuvant therapy with the intervention 4 days prior to intervention and continue for 1 month or 3 months after intervention. And it is used in inoperable cyst, multiple or multi-organ cyst, in case of recurrence, in cases of patients who are surgically unfit. So these patients, medical line of treatment have helped, and it is the better modality than any other treatment options. While using albendazole toxicity should be monitored by symptoms like pain abdomen, nausea, pruritus, dizziness, alopecia, and headache. Occasionally, there can be leukopenia and eosinophilia, and there can be mild elevated transaminase. Contraindications, large cyst, honeycomb cyst. It's not absolute contraindication, but it is found that they may not be that much effective compared to the above mentioned uh, cases. Calcified cyst, it would definitely won't help. Albendazole should not be used during pregnancy. Caution should be taken. The next line of treatment is otherwise called as PAIR, that is puncture, aspirate, injection, and reaspiration. It is tried in patients who are surgically unfit and also in the classification which I mentioned, CL and CE1, 2, and 3, and also in patients who has a relapse of the cyst, infected cyst, children less than 3 years, cysts more than 5 centimeters in different liver segments, that is multiple cysts, which are more than 5 centimeters, PAIR can be tried. PAIR has got its own problems. The patients can have fever, a secondary infection of the cyst, which was sterile. There can be anaphylactic reaction where there was intra-abdominal spillage, leading infection, as I mentioned earlier. And there can be, in spite of PAIR, there can be a 4% chance of recurrence, wherein repeat PAIR can be tried. Due to other problems like bleeding or injury to vital structures during the procedure, there have been reported mortality of 0.9 to 2.5%. As I mentioned earlier, endoscopic treatment has also been tried, is useful in the presence of an intrabiliary rupture of the cyst, helps in drainage of the biliary tree. The hydatid material can be expelled with a balloon catheter or a Dormier basket, as we do for a common bile duct stone. Endoscopic sphincterotomy help to facilitate the drainage of the common bile duct, and the cyst which can pass through can get eliminated into the intestines thereon.
1 minute,
Yes, sir.
Mahesh. There are one comment. Just go back to previous slide. I don't think you can say endoscopic treatment also to be tried. It is only for reserved for cases where there is an intrabiliary
Yes, sir.
rupture
Yes, sir.
and obstructive jaundice, or there is a pain and cysts are stuck in the biliary
Yes.
tree. That is the
Yes,
endoscopic
but
treatment.
first,
Otherwise, intrahepatic and cyst or anything, it will not be
yes,
useful.
only the first line only I mentioned, useful in presence of intrabiliary rupture, sir. Yes, sir.
Correct, correct. It's
That only for that one, so not for any other this ones. And it's also been
so Dr. Nawaz is asking, what is water lily sign or camelot sign? I think you mentioned also. You can, or anybody else wants to say what is water lily sign? Postgraduates, anybody? Pavan, so many people are there, no? Madan.
Sir, water lily sign is the breaking of the endocyst from the ectocyst, sir. It will be freely movable within the cyst cavity. When it is radiologically seen, it's called as water lily or Cameron sign, sir.
Detached laminated membrane. No? What is camelot sign?
Both are same, sir. Synonymous.
No, no, no. No. Dr. Mahesh already explained actually.
Sir, when there is a rupture, intrabiliary rupture, there cyst wall will collapse.
Correct.
So that is.
So it indicates cyst biliary fistula, right?
Yes.
Some
Yes.
amount is drained into the biliary tree.
When there is an intrabiliary rupture, the partial collapse of cyst wall, that is chemolytic signs.
Right. Dr. Naz, you want to come and explain anything?
No, sir.
Anything more on the Waterloo sign and Camelot sign?
I just wanted to ask whether how do you, in what cases you do an MRCP in these patients? Sir? When do you decide to do an MRCP?
MRCP, as we discussed, you do if there is jaundice. See, the jaundice in these cases can come because of two things. One is the pressure effect on the bile duct, or there is a biliary cyst rupture.
Fistula, sir. Cyst biliary fistula.
So when there is a Camelot sign, should we do a MRCP? That's what my question is.
I think so, correct. It
Yes.
should be.
Yes. Okay.
Mahesh?
Yes, sir. Correct.
Yes.
So these are all signs which are mentioned, but I don't think anybody following those things very much, the signs, but whatever is radiologically seen and all, they will be definitely treated accordingly.
Sir, serology, is it necessary to do serological tests like ELISA and all they have mentioned in textbook?
Yeah.
It is not necessarily, sir. Actually, only rather than diagnosing, they help only to get to know any further chances of recurrent cyst. But there's no much of a importance. Radiology, that is ultrasound, finds the main modality of investigation of choice when it comes to suspected cases of hydatid cyst and treatment, sir.
Okay, sir.
But CT scan has 98% sensitivity.
Yes, sir.
I think, I don't know, anybody will operate or treat hydatid disease just on ultrasound, or they will
Without
CT scan also.
Yeah, that's what I mentioned, sir. It will help in planning the surgery. That's what the CT scan will give us, sir. Diagnosis, yes, ultrasound, but when we plan for surgery, definitely a CT scan will help us to see the number of cysts, the location of cyst, and the size and everything.
Dr. Ravi Shankar, you have any points? Unmute.
I think ultrasound is an initial investigation to give us an idea, because many of these, as Mahesh has very clearly elucidated, many of them are asymptomatic. So when you do an ultrasound scan, it will tell us that there is hydatid disease. So when you plan surgery, then you definitely need CT or a combination of CT and MR, which will give us a good idea.
Right. Thank you. We'll move ahead, Mahesh.
Okay, sir. Coming to discuss about the surgery. Surgery is increasingly being replaced by other options in uncomplicated cysts like the drug therapy, pair procedures. It maintains a central role in complicated cysts which are at high risk of rupture, or a large cyst with many daughter vesicles that are not suitable for percutaneous treatment. Important thing to remember while planning or while operating on a hydatid cyst is to isolate the area, to aspirate small amount of fluid that would reduce the pressure in the cyst before exploring, and to use scolicidal agents which can be installed into the cyst, and various scolicidal agents has been recommended like hypertonic saline, then diluted Savlon, and any sort of these irritants would help to will act like a scolicidal agent, and the aim should be to totally evacuate the infected contents. As I mentioned earlier, the operative goal or the principle should be to inactivate the infections the cyst contain, prevent spillage, evacuate all viable elements, manage the residual cavity, which is very important, and the management of communication between the cyst and the adjacent structures. So these are the important goals or the principles should be kept in mind while operating on a hydatid cyst, be it laparoscopic or open method. So this is just a, so, yes, sir.
Can I come in? A question for postgraduates. Yeah,
Yes, sir.
talking about scolicidal agents instilled in during surgery. Previously, alcohol used to be used, absolute alcohol or 70% alcohol. Why have they stopped using it? And under what circumstances you would definitely not use it? Any of the postgraduate can answer that question. Probably no answer is coming. See, alcohol can destroy the biliary radicals if you inject it. So that is why it is no longer being used. I think it is now hypertonic saline, or as Mahesh said, dilute
Citramide.
cetrimide.
Citramides.
Cetrimide. The especially when you see that there is possibility of cyst biliary radical communication, you certainly should not use the absolute alcohol, because if it gets into the biliary system, it can cause severe sclerosis and
Sclerosing cholangitis.
cholangitis and damage to the biliary tree. So absolute alcohol or 70% alcohol is given up now as a scolicidal agent. Before, that was the commonest scolicidal agent used.
Sir, can we use in gastric varices? I had read that they were using absolute alcohol previously.
For what?
Gastric varices, sir. Varices.
Again,
Variceal bleeding.
yeah, for variceal bleeding, you have excellent sclerosing agents now, so you don't need absolute alcohol. Again,
Okay.
you have a lot of them. Again, sclerosing agents are no longer being used because you have rubber band ligation, which is the treatment of choice now. So I think again, sclerosing agent injection sclerotherapy is almost given up for portal hypertension.
Okay.
Right.
Sir, 10% povidone iodine can be used?
Yes, sir. Povidone iodine is also used. Definitely. Mahesh, any other scolicidal agents?
Hydrogen peroxide also they use, I think.
Yes, sir. Diluted.
Diluted and may not be safe inside the peritoneal cavity or any contact. I think most common is cetrimide, 1%,
Citramide.
right? Then is povidone iodine and
Hypertonic salines.
Hypertonic saline.
these are the three things used. Other things like alcohol, Dr. Ravi Shankar rightly mentioned, and also hydrogen peroxide, I have not seen mentioned in any books also, and I don't think, sir. Any other thing, Dr. Mahesh?
No, so these are the commonest things used actually. Yeah.
Mahesh sir, how you manage this residual, cavity? We
I'm coming
used
to
to
that, sir.
use the momentum.
No, there is a lot of other procedures. I'm coming to that, sir.
Okay, sir. Thank you.
Okay.
Continue.
Shall I proceed, sir? Yes, sir. These are just operative pictures, and here you can see that this is a laparoscopic picture wherein before opening the cyst is well isolated with the mops, and some people do use colored mops to make sure they are in place. This is the lot of daughter cyst which has been expelled from a laparotomy procedure. So surgery coming to manage, apart from draining the cyst and taking care of that, you have to take care of the residual cyst. Sometimes it can be a huge one. So the management of the remaining cyst is an important, as Dr. Nuli was just now asking. So there are various methods, that is marsupialization, deroofing of the cyst, then omentoplasty, which is one of the best method and which is the method which is recommended to prevent further issues with the cyst. And you can also use a drain and drain the cyst. So these are the modalities used to take care of the remaining cavity. This is a typical picture showing a marsupialization of the cyst wall to the adjacent sites of the liver. This will help in preventing recurrence as well as adequately draining the cyst or any fluid secreted with the help of a drain. And this can be actually sometimes covered with the post of the momentum tailor-made to take care of this permanent cavity. And coming to the various instruments used, and throughout the history, people have tried various modalities and various instruments to drain this. In the laparoscopic era also, initially there was problem sucking and aspirating these cysts, and Dr. Palanivelu has come with a system which helps in sucking and aspirating simultaneously without causing spillage, and it is widely being used now and is named after him. And this is the picture which is represented here. And this is a study where there is a comparison of laparoscopic approach with the conventional technique, and all studies have pointed out that laparoscopic approach is the safer method, and it is not inferior to the open method, and it can be widely practiced to take care of these hydatid cysts.
Mahesh, can
Sir.
I come in? Yeah.
Yes, sir.
Shivram, can I come in?
Sure, Ravi. Please go on.
Yes, sir.
See,
Tell
I
me,
think
sir.
for the benefit of postgraduates, I think we should just elaborate on the surgical procedure. So I think the CT scan and MR would have given us an idea as to where exactly the cyst is, and many of them sometimes may not be on the surface. So you should know exactly where the cyst is, as Mahesh very clearly elucidated, that which segment is involved. So you should know your segmental anatomy of the liver before you attempt, especially laparoscopic surgery. And after you have entered, you basically use the 10 mm camera and a 10 mm sucker. I think that is very important. Or Palinivelu's, I have not used it, but I use a 10 mm sucker. And then basically, as again, Mahesh very clearly said, you have to reduce the tension in the cyst so that it doesn't spill. So do an aspiration initially, and then make an incision over the liver surface enough to let in two instruments. One is the camera and the other one is a 10 mm sucker. So then you go in under vision. The camera is in this within the cyst wall, within cavity of the cyst, and then you aspirate using the 10 mm, so that you aspirate all the daughter cysts and make sure that you have curated the cavity completely. And other advantage of this is that if you see any biliary communication, you have to suture it at the same time. You can't leave it so that because then you will have a fistula which will continue to drain, because
Yes.
it's a large cavity, and it takes a long time to collapse. So you'll have a long standing biliary fistula. So when you see a biliary communication, you have to suture it, and then you have to follow this process of instilling the hypertonic saline or whatever cholicidal agent, and then leaving it for a period of 4 to 6 minutes, and then aspirating it, and then do this 2 or 3 times, and ensure that the cavity is completely cleared of all the daughter cysts under direct vision. So the camera has to go into the hydatid cyst cavity, and then after that you complete it, then again what Mahesh said about marsupialization or omentoplasty, and ensure that you have sutured the biliary communication if you found any. So these are the steps that you have to take to ensure that you have dealt with properly. And while you are there, when you are doing a diagnostic laparoscopy, look at the spleen, look at the general abdominal cavity, and make sure there are no other hydatid cysts. Sorry for interruption.
No problem, sir. Rightly said, sir. Yes. Thank you, sir.
Sir, what is the enteroplexion you had mentioned in your slide? Here, enteroflexion after omentoplasty.
Interflexion is a method where it is similar to marsupialization, but the edges are little brought together if possible, if it is lax, and try to reduce the space in the cavity, sir.
You are suturing it, sir?
Yes, sir. Yes, sir. Yeah. Just to bring it together to reduce the space so that the approximation is there, sir, with the momentum, sir.
Okay.
Thank you, sir. Coming to the contraindications, complex or a widespread affection, advanced age and severe comorbidities, pregnancy, and multiple cysts that are difficult to access. And as I mentioned earlier, a calcified liver cyst need not be dealt with. Complications, as it was mentioned earlier, biliary leakage, which is the commonest and most frequent, occurs in almost 50% of cases due to a small undetected communication between the cyst and the biliary ducts. With surgery, a mortality of 0.9 to 3.6 has been mentioned in a couple of papers. In spite of surgery, there can be a recurrence up to 10 to 11.3% within 5 years. Surgery can carry progressively higher mortality, which can increase 20 in the fold of 20% with every surgery. Another thing which can happen is wound infection, most commonly in the open method. So these are the complications which are mentioned with a surgery, whether it is laparoscopic or open. As Dr. Ravi Shankar mentioned, the biliary communication should be taken care if it is visible, but sometimes it can go unnoticed, and post-operatively we can see with the drains which are in place, which has to be dealt with depending on the imagings which we have done. And another problem was the wound infection.
So what
Any questions here, sir?
while
Sir, on table, biliary communication, Ravi Shankar sir, will you please explain means how to laparoscopically when we are looking at that? How will you give me some hints to look at the communication biliary? How to look at that? Whether
Sir,
there is biliary communication or not?
that is what I said, sir. You use a 30-degree camera, and then where the camera has to go in the cyst, and then you thoroughly debride and remove all the daughter cysts and everything, and then the clue will be if there is any bile leaking out while you are doing that. So then you can use a gauze piece to find out where the bile is leaking from. As Mahesh said, sometimes the communications may not be that obvious, but the important thing is whenever it is obvious, you can't just leave it like that. You have to suture it
Yes.
at the same time.
Sir, how do you suture it? With what suture material? And means, I'm sorry, you please explain.
Vicryl or PDS. I think you can just 2 or 3 0 Vicryl, and you suture the bile, the duct. That usually it will be a side wall. So if you just take a figure of 8 stitch, I think that should be sufficient. Depends on the size of the leak.
Now, post-operatively, if there is a biliary leak afterwards, what investigation we should do? ERCP will help.
Yeah, because if you see that there is continuous, you don't have to act on it. If you look at the amount of biliary drainage, so if the biliary drainage is consistently above 200 or 250 ml over 24-hour period for a period of 10 days or more, then you probably do an ERCP. And many times you may see a leak from one of the ducts, so you can stent that, and then that will stop the leak. But otherwise, majority of them will stop on their own as the cyst wall collapses and the body heals itself. Shivram, any addition to that?
if it
Colicidal agent will not have a bad effect on that biliary communication, sir. Whatever colicidal agent we put, if there is a really biliary communication.
That is why I said, previously they used to use alcohol, and that would definitely cause a lot of damage. Nowadays, because either saline or cetrimide or povidone iodine are not particularly harmful. If it if it goes in, I don't think it's a problem.
Okay, sir.
right.
Shivram, any addition?
No, the biliary sphincterotomy can help if there is a post-operative bile leak. It will reduce the biliary pressure.
Correct.
It stops.
Correct. Absolutely correct.
One thing Dr. Mahesh has not spoken is about the radical excision of the cyst itself, doing a liver resection. Anything, Dr. Mahesh, you have read about it?
Not much. I didn't read about it in detail, sir. Yes.
Correct. Especially if there is a recurrent disease, many of the liver surgeons prefer to do segmental excision or
segmentectomy.
Including excision of the pericyst. So that is supposed to give better results than just marsupialization or momentum plugging, these things. There are some questions. Dr. Ajit is asking when to do omentoplasty, interflexon, or capitonage.
This is the choice of the surgeon. Most of the time, momentum is used depending on how they are trained. There is no any particular uh, reason for a different method. It's the convenience of the surgeon. Most of the time, omentoplasty is the best modality, and with marsupialization.
Okay.
See, if you have a very large cavity and you should not leave the cavity left open, it may again form some fluid or cyst in that. So in such situations, better to put momentum inside and fix it up so that whatever fluid accumulates or anything, it gets absorbed into the momentum. But if you have done a very good marsupialization, which photo Dr. Mahesh said, there you can't do omentoplasty. So there you have to do an excellent marsupialization that can prevent recurrence.
Yes.
Age is approximate like a liver section and excision of the pericyst also. Dr. Ravi, you have something more to add?
No, I think you're right. I think what Mahesh very clearly said, there used to be an innumerable number of procedures before, including liver resections, which I think it has become minimalistic now.
Minimalistic, yes, sir.
So basically, the surgical intervention itself is less, and
Less,
whenever you
yes.
have to intervene, you use laparoscopic methods rather than open method because it's much
Open
better.
method.
And even when you do laparoscopy, you do the least minimum you need to do, and I think majority of them do very well. Radical resections, as you said, for recurrent, and where you can actually do either an anatomic or non-anatomic resection.
True. Dr. Noli, sir?
Sir, radical resection, if I looked at the literature also, radical resection are first paper from one of the gastroenterology journal, is it the best resection, best option like that?
Right.
But it all depends on, as we told, very big cavity, and second one is recurrent.
Right.
Otherwise, the resection, liver resection is not yet mentioned, sir.
Right.
Okay, sir.
Mahesh, last.
Yes, sir. Yeah, to conclude, just to have a summary of this, human echinococcosis is a parasitic disease caused by tapeworm of genus Echinococcosis. More than 1 million people are affected with echinococcosis at any one time. The two most important forms are the cystic echinococcosis, that is Hydatid disease, or the alveolar echinococcosis. Humans are infected through ingestion of parasite eggs in contaminated food or water or soil, or affect direct contact with the animal host. Echinococcosis is often an expensive and complicated to treat and may require extensive surgery or prolonged drug therapy. Preventive programs are important, focus on deworming of dogs, which are definitive hosts in the case of cystic echinococcosis. Preventive measures also include deworming dogs, slaughterhouses, hygiene, and public health. And anti-helminthics serves as an important adjunct to surgical or the percutaneous therapies. Should be cautious in pregnancy when using anti-helminthics. Radical surgery is a better option than conservative surgery in the other cases which we just now discussed. Omentoplasty is one of the effective way to prevent postoperative complications. Percutaneous drainage combined with albendazole therapy is a better alternative to surgery whenever indicated. Laparoscopic surgical approach for liver hydatid cyst and VATS for pulmonary hydatid cyst is recommended and safe.
Sir, my question is for postgraduates. What's the important question you ask for the patients in the history, or if you are suspecting Hydatid?
Yes. Any postgraduate?
Pet animals like dog.
Yeah,
Pet animals, sir.
Animals.
and pet animals, and next.
Sheep grazing.
Postgraduates are not actively participating, Ravishankar sir.
That's the problem.
ನಾವೇ post graduates ಆಗಿದ್ದೀವಿ.
We are learning.
Ask questions, so they hesitate to ask questions, I think. No? Dr. Chayapati, you have raised hand. Please unmute and speak. Dr. Chayapati.
Pets is one. Next, what? Any other questions you would like to ask?
Then farmers are like
Shepherds,
working in
shepherds you should ask. Shepherds are more in number. I don't know in Bangalore, but in our side, shepherds everywhere they will be there. Shepherds.
So occupation, that is very important.
Occupation is very important. Correct.
Hello.
Yes, Dr. Chayapati.
Sir, how do you treat ruptured hydatid cyst into the abdominal cavity?
Right. Dr. Mahesh, you want to answer?
It can be dealt with laparoscopy or
Multiple
open
cysts in the
method.
abdominal cavity, whole of the abdomen cavity.
So that can be dealt with laparoscopic or open method, depending on the condition of the patient. A thorough wash and lavage should be taken care, and care should be taken to evacuate completely all the hydatid cyst, and a drain has to be placed, and they should be continued with the drug therapy as mentioned earlier.
What type of drain you should keep, sir?
We should keep a bigger drain for these cysts to come out. Anything above 32 is always recommended for the cyst to get drained if there are any remnants. But I think surgical surgical lavage, or if the laparoscopic approach is inadequate, better to open and make sure all these cysts are removed and a thorough wash is given and the drain is placed, sir.
Right, Dr. Chayapati, I will answer because I have managed 2 of such cases.
Right.
I don't know anybody else has managed.
Okay.
These cases, laparoscopy very difficult to treat because many times small cysts would have scattered all over the abdomen.
Yeah, that's what, sir. So much
If it is
huge
inadequate, then
burden.
better to do open method.
Yeah.
Come with some signs of peritonitis.
Right.
So they require, in my opinion, they require a good laparotomy and also use of this cetrimide or betadine, and enough of time to see everything is nothing is left inside the abdominal cavity. No, none of the small cysts or so.
Right.
I have, my opinion is not to keep the drain because
Yeah, that's what, sir. Yeah.
the drain it can. So better not to keep the
Drain. Yes.
Also take time sterilizing the abdominal cavity, and immediately after surgery put them on albendazole.
Right.
6 months.
My one patient, it recurred, and again we had to go for the liver surgery, and a small cyst again appeared. Actually, now last 20 years she is on intermittent therapy of albendazole.
20 years.
So I give them 1 month, 2 months rest, and again 1 month, like that. And most important is to monitor their liver function test and also the blood counts. They may
blood counts.
We have to very carefully monitor these patients.
Right. Thank you, sir. Thank you. Thank you.
Experience, please share, Dr. Ravi.
I agree with you. I think basically it is like doing sugar baker, the operation that you do for sugar baker operation for the pseudomyxoma. You have to be that thorough. It may take 5 to 6 hours. You have to ensure that you have removed all the cysts and then give thorough lavage and then come out. It is very difficult to treat, and then they have to be on as you said, long-term anti-helminthic therapy also as well. I think another thing is, I don't know whether there is any wisdom in this, but majority of our anesthetists give them steroids before we start the surgery. Whether there is any wisdom in this to prevent anaphylaxis, I don't
Anaphylaxis.
know.
Anaphylaxis.
Yeah.
That is the scare about anaphylaxis.
Yeah. So steroids, and they keep adrenaline ready. They won't give it, but steroids certainly they give.
Right.
Yes, sir.
Dr. Nas? Dr. Nas, you have some questions, comments?
Yeah, it was a nice presentation and a good discussion, sir.
Thank you, madam.
I put up my question and you already answered it, sir.
Yeah. I think the gap we give,
Yeah, to
and then
look
give.
at the liver function test and for bone marrow suppression.
Correct.
Sir, how long to follow up, sir, patients?
Lifelong.
Lifelong.
And ultrasound, anything we have to repeat at what intervals?
These are not very clear. At least once in 6 months, better to repeat.
Yeah.
Okay.
Dr. Nuli, sir, final comments? Right. So if there are no more questions, shall we conclude? Dr. Ravi?
Yes, I think,
Yes, sir.
Mahesh, congratulations. Good presentation. You have touched on all the important, relevant parts for the postgraduate. So very good sign of a very good teacher.
I think
Thank you, sir. Thank you.
postgraduates are very attentive. They can definitely write a good answer in the examination, and also if there is a clinical case, this will be very useful. Thank you, Dr. Mahesh. Congratulations.
Thank you very much for the opportunity, sir. Thank you, sir. Good
Thank
night,
you.
sir.
Good
Thank
night.
you, sir.